Dr. Jeff Lee specializes in cardiac electrophysiology, and I'm going to let him explain to you what an electrophysiologist is. That includes pacemaker and defibrillation implantation, as well as ablation of complex atrial and ventricular rhythm abnormalities. He's board certified in cardiovascular disease, cardiac electrophysiology, echocardiography, nuclear cardiology, and internal medicine. Dr. Lee received his medical degree from Northwestern University and completed his residency in internal medicine at Emory University in Atlanta. He then went on to a fellowship in cardiovascular disease at the University of Pittsburgh, followed by a fellowship in electrophysiology at the Cleveland Clinic. Dr. Lee provides care to patients at Inova Alexandria, Inova Fairfax, Inova Fair Oaks, and Inova Loudoun hospitals, and he sees patients in the Virginia Heart Loudoun and Fairfax office locations. So at this point, I'm going to turn the program over to Dr. Lee. A reminder again, for questions, please put them in the Q&A box, not in the chat. Dr. Lee, we look forward to your presentation. Thank you.
All right. Well, thanks, Dr. Levy. I'm going to go ahead and start sharing my screen here. And so, yeah, we're going to talk about atrial fibrillation. Obviously, a big topic that we go over a lot. It's probably the #1 reason I see patients, both in the hospital and in the clinic. And so we do it a lot. And I'm happy to talk about it and share kind of really one of the themes I want to talk about with this is that managing atrial fibrillation is a journey, and everyone's journey is a little bit different. Everyone takes this path or that path, and it depends on how just the atrial fibrillation affects you. So, that will be a theme of my talk. You're going to hear me a lot saying things like, well, some patients have it this way, and some other patients have it this way, and this therapy is good for this patient, and this therapy might not be so good for this patient. So a lot of it is personalized. And so I just want to really emphasize that. That will be a theme of our talk. And then I'm looking forward to just having a good discussion and hopefully answering some of your questions. So to get started here, the question is, what is atrial fibrillation? And we look to what the normal electrical activation of the heart is. So if you look on the left here, this is normal electrical activation of the heart. So the electrical impulses that dictate our heart rate come from the sinus node or the sinoatrial node, and it sends an electrical signal to the rest of the heart. These chambers of the heart called the ventricles that pump blood to the rest of the heart, and it does that with a steady cadence. So we see a normal sinus rhythm on an EKG. You can see that this has a steady cadence. The intervals between these electrical spikes are constant. However, when you have atrial fibrillation, you could see that the normal activation of the pacemaker is hijacked, and you have this electrically chaotic rhythm in these chambers of the heart called the atrium. And this chaotic electrical activation leads to chaotic, irregular heart rates of the bottom chambers of the heart called the ventricles. So what you will see on an EKG is that the EKG looks very irregular. You can see that certain intervals of these electrical spikes are very irregular. And that's the hallmark of atrial fibrillation, is the irregularity of it. Now, what can atrial fibrillation feel like? Well, again, going on our theme, everyone experiences it very differently. There are some patients who can feel pretty severe symptoms. Some people feel breathless, they can feel palpitations, chest discomfort, feel very lightheaded. And then on the flip side, it can be very subtle. Sometimes it's just a little bit of tiredness or weakness. Sometimes it's just they feel fine at rest, but then whenever they climb up their flight of stairs at home, when they happen to be in atrial fibrillation, they struggle a little bit more climbing up those stairs, but otherwise they feel pretty okay. So it's not uncommon that we can have these arrhythmias. Atrial fibrillation can be found incidentally, where they feel fine, they don't even know they have atrial fibrillation, and then they show up to their doctor one day, and the doctor listens to their heart, and they say, whoa, your heart rate is a little bit irregular here. And then they do an EKG, and lo and behold, you have atrial fibrillation, and that's completely a shock to the patient because they had been feeling kind of okay. So really, this is an important thing to learn. Whenever I talk to patients, really learning about their symptoms is so critical to dictating the approach, because the severity of the symptoms will dictate how aggressive we get with it. Obviously, the patients who have severe symptoms, they feel chest pain, palpitations, it's completely limiting their life. They'll do anything to get rid of the AFib. They'll do drugs, they'll do procedures, they'll do anything just to make this go away because it is really limiting their life. Versus there are some patients who don't feel really much at all. They don't feel that much different when they're in atrial fibrillation versus not. And those patients tend to be a little less excited about undergoing procedures for atrial fibrillation or undergoing medication. So really, it's very individualized per patient, and that's because it's just different how patients experience atrial fibrillation. Now, how serious is atrial fibrillation? And you may hear people say that atrial fibrillation is not a dangerous or malignant arrhythmia, that people don't drop dead from atrial fibrillation. And generally, that is true. But atrial fibrillation can increase the risk of some life-threatening and life-limiting conditions. So it can increase the risk of blood clots, which can lead to strokes, which we will talk about. And then it can also lead to the heart getting weaker. And when the heart gets weaker, we broadly term that heart failure. So atrial fibrillation, it is something that we do like to catch because it can increase the risk of that. So even though everyone experiences it differently and people can have some subtle symptoms, it is something that we have to take seriously and not blow off completely, which is why I think seeing a cardiologist or seeing an electrophysiologist is definitely worth doing. Now, how does atrial fibrillation cause a stroke? I know that's one of the main ways that this can be serious, and this is a critical part of managing atrial fibrillation. Well, there's this idea that in the atrium, I showed you in that diagram before, that the electrical activity can be very chaotic. And that chaotic electrical activity causes the atrium to not really contract or squeeze like it normally does, but it can just fibrillate. It just doesn't move very well, the blood inside that chamber. And so because the blood inside that chamber of the heart cannot flow as well when you are in atrial fibrillation, that can predispose to the formation of a blood clot. And if a blood clot forms inside the atrium and leaves the heart and goes to the brain, that can cause a stroke. And that's obviously one of the most feared complications of atrial fibrillation is the risk of stroke. So we'll talk about it later, but a lot of our patients with atrial fibrillation do end up on some kind of a blood thinner. Now, people always ask, well, I had atrial fibrillation, but it kind of went away. They had a brief episode of atrial fibrillation. They were diagnosed with it, but then they haven't had recurrences for some time. And so they think, will this just go away? Maybe I'll just outgrow this. And unfortunately, the answer is no. Really, that's because there is this inexorable, almost inevitable progression that atrial fibrillation has. And there certainly are some things we can do to mitigate that progression. But just left to our own devices, we can see that atrial fibrillation tends to progress over time. And so usually when it first starts, you could see over here, there is this area termed paroxysmal atrial fibrillation, meaning that atrial fibrillation comes and goes. So you can see these gray bars here represent atrial fibrillation, just short little episodes of atrial fibrillation, and they don't last forever. They just come and go. But then over time, these episodes can become more frequent and then start to become longer and more persistent. And we have this saying, atrial fibrillation begets more atrial fibrillation. So what atrial fibrillation can do is it can cause what we call AF-related remodeling, where your heart actually changes and it can dilate and it can scar, and that predisposes to more atrial fibrillation. So if this trend continues, the atrial fibrillation becomes more persistent. These episodes start to last even longer. So that the remodeling changes, the atrium dilates further, it scars further, and then it gets to the point where you go into what's called permanent atrial fibrillation, where you're just locked in and it just gets really difficult to remove atrial fibrillation. So there is some value when we're dealing with atrial fibrillation to nipping it in the bud, so to speak. So having an early intervention, we are finding can be critical to the success of preventing and slowing down this progression. And we'll talk a lot about the ways in which we can do this. So how common is atrial fibrillation? Again, it's the #1 most common arrhythmia in the world. And we can see that in the United States and North America, it is incredibly common. We have a high prevalence of this. And again, there's a lot of reasons for this. A lot of it is our aging population. So age is one of the big factors of it. And really it's a commentary on the health of our country. As we talk about some of the causes of atrial fibrillation, you'll see that given the multiple causes and multiple factors that lead to it, that it would be no surprise that the U.S. is probably #1 when it comes to the prevalence and frequency of atrial fibrillation. So I'm sure a lot of you on the call today have a lot of people with atrial fibrillation. Even if you have it yourself, you probably know some people who also have it. So It is a very common experience for a lot of our patients. This slide, it's a little bit outdated, but I wanted to show this just to give you some numbers about how frequent atrial fibrillation is. So we see that once you get to the age of about 70 years old, about 10% of patients have atrial fibrillation. So that's a lot of atrial fibrillation. If you think about every 70-year-old out there on the street, 10% of them are going to have atrial fibrillation in one form or another. It might go undiagnosed, but a lot of them have it. And as we age, as we get to more 80 years old, we believe that the prevalence increases to 15 to 20%. And there are some estimates, again, this is from 2004, probably 20 years later, it's probably higher. And there are some estimates that believe that 1 in 4 patients above the age of 40 are going to go on to have atrial fibrillation at some point in their life. So in some ways, it's not a question of if are we going to get atrial fibrillation, it's when are we going to get it. And there's almost it's just such a frequent thing. So you're not alone if you have atrial fibrillation. It's a common thing, but that means we do have a lot of experience in dealing with it. Now, what causes atrial fibrillation? I said we talk about this. As you can see, there is a long list here of what can cause atrial fibrillation. So one of the big ones here is aging. Like I showed you in that graph, in that last slide, that it tends to happen more as we age. There is some thought that certain genetics or ethnicities, being male, might predispose you to a higher risk of atrial fibrillation. And then you've got a panoply of different diseases and issues that can definitely make atrial fibrillation worse. If you have heart failure or valvular disease at baseline, you're at higher risk. If you've got high blood pressure, that can cause it. If you're inactive, if you drink alcohol, if you're obese, that can all contribute to it. Having a lung disease called COPD. So it is never just one factor that leads to atrial fibrillation. Everyone's always looking for, what is that one thing that caused me to have atrial fibrillation? What did I do wrong? Or is it my genetics? And I always tell them it's not just one thing. It is probably a confluence, a combination of multiple factors. And so because it is multiple factors, there's no just one single fix you can make that will make it all go away and prevent this progression, just because there are so many factors that go into it. And certainly the one factor you cannot change is age. And so that contributes to this idea that this is a relentlessly progressive disease over time. Now, everyone always also asks, well, what triggers atrial fibrillation? And that's always hard because, again, we talked about how in the early stages, atrial fibrillation is what we call paroxysmal, meaning it comes and goes. It's not there all the time. And people, they can feel these episodes of atrial fibrillation. It comes and goes. And so people are always asking, well, what did I do? They go into atrial fibrillation and they look back, okay, what did I do to mess myself up like this? And certainly there are some potential triggers where we commonly see atrial fibrillation. So current illness, if in surgery. So we see this all the time in patients in the hospital. Patients are sick, patients are ill, patients are infected, they're getting surgery, and they get atrial fibrillation during those kind of medically stressful times. Alcohol is a known trigger for atrial fibrillation. If someone's very dehydrated, stress can potentially do it. Extreme amounts of exercise. There's been some studies looking at air pollution being a cause. Coffee and caffeine, that link is actually not so strong for atrial fibrillation. That's been somewhat of a weak association. And so it gets to the idea, people always say like, I think it was that coffee I drank or that espresso I drank, but sometimes that's not what it was. Again, it's really hard to prove cause and effect. And sometimes, I've had patients who blame it on like the meal they had last night. They said, oh, that burrito I ate last night, I really think that's what caused it because, it was a little too spicy and then the AFib happened. But, they've had the burrito other times and then they didn't get AFib. Or maybe it was something else. Maybe you were dehydrated. So I think for any one individual patient, it is hard to really prove cause and effect. Now, we know that generally there are certain triggers that we do tend to see. But again, we have plenty of patients who are having surgery, and it's not like they always get AFib during those times. There are patients who have alcohol, even though they have a known diagnosis of atrial fibrillation, and they don't always get AFib even after that drink. So again, it's just atrial fibrillation is going to flare up when it wants to flare up, but certainly there could be some triggers that might predispose you to it. Now, how do we diagnose atrial fibrillation? And there are multiple ways that can be done. So again, we talked about how the physical exam, someone listening to your heart and noticing that it is irregular, that can be a tip-off, that's atrial fibrillation. And ideally, you want to confirm this with an EKG. And then there are other devices that can be used to confirm atrial fibrillation. So here we can see an EKG showing that irregular rhythm that I showed you earlier. And now there are all sorts of devices out there that are helping us to diagnose and catch atrial fibrillation. So there are all these watches. There is the Apple Watch and the Samsung watches and all these wearables and Fitbits that now have the capability of alerting you when they can detect that your heart rhythm seems irregular. And they're not perfect by any means, but they're pretty good. Sometimes they can pick it up. And so preferably you want to try to get an EKG when the episode of atrial fibrillation is occurring. There's also these devices where you can kind of spot check what your heart rhythm is, and it can give you an EKG tracing telling you if you're in atrial fibrillation or not. And then there are also monitors, like little stickers that you can put on your chest that monitors your EKG for a period of time. And then there are implanted devices, devices that go under the skin. It says ILR, that stands for an implantable loop recorder. And that is a monitor that is always getting an EKG on you 24/7, 365. And it's a device that's planted under the skin. So that can be a way that we can catch atrial fibrillation. So lots of ways to do it. And with the proliferation of all of these devices and wearables, that has meant that atrial fibrillation, we're catching more and more of it. And it has been good for business for us. A lot of patients walk through my doors because their Apple Watch told them that they have atrial fibrillation. So business is booming. We're catching a lot of atrial fibrillation. And, I think we're able to help patients in a timely manner because they're able to catch it. So we're going to be referring to this slide a number of times because this is one of the big topics is how do we manage atrial fibrillation? And there are 4 pillars that we have to address when we're talking about treating atrial fibrillation. So what we have here is lifestyle modification, what we call rate control, which I will explain, something called rhythm control, and then preventing strokes. So these are the 4 pillars. And then on the foundation is assessing and optimizing these comorbidities. We talked about all of those other causes that can predispose someone to atrial fibrillation. So if you're obese, losing weight, if you have sleep apnea, treating that, treating high blood pressure, treating diabetes, heart failure, CAD is coronary artery disease, if you've got blocked arteries. So all of that is, again, it's never just one factor. You've got to hit them all. You've got to address all of these if we want to be successful in dealing with atrial fibrillation. And again, going to that idea of everyone's journey being a little different, everyone's going to have a different kind of list of issues that they've got to deal with and contend with. And so that's why having a good electrophysiologist who can personalize your treatment is really critical. So just talking about this foundation first, it's lifestyle modification. There is a lot of good literature, a lot of good research to show that these lifestyle changes really can help. So losing weight is a big one. Treating obstructive sleep apnea, treating high blood pressure, treating diabetes, minimizing alcohol, and stopping smoking. And there was so the American Heart Association recently had their big presentations this past week, and hot off the presses, there was a study looking at intensive lifestyle modification as an intervention for atrial fibrillation. And there was a pretty dramatic improvement in atrial fibrillation frequency with very aggressive, targeted modifications of these risk factors. So it just proved to the point to all of us that this stuff really worked. And admittedly, as an electrophysiologist, I don't get to talk about all of these in depth as much as I would like. But a lot of this has to do with the motivation of the patient to really want to try to get better and improve their heart health. And this is such a critical role of it. And so just partnering with your primary care doctors, your general cardiologist to deal with these is really a foundational element of treating atrial fibrillation. Now, we're going to talk about rate control here, the second pillar. And when people go into atrial fibrillation, we talked how their heart is irregular, but what it also does is it makes your heart go fast. And everyone is a little bit different. We have some patients who, when they go into atrial fibrillation, their heart rate is really fast. Like their heart rate's going 180 beats per minute, 190 beats per minute, and they're not going to feel good. Anyone going with their heart going that fast, they don't feel good. And so really one of the first instincts that we have to try to treat patients who come into the emergency room with atrial fibrillation is let's just try to get their heart rate under control. Let's just make it more manageable for them. So if you can get that 180 beat per minute of atrial fibrillation and you can get it down to something more manageable, like 110, 120, you're going to feel better. So, on the bottom left, you can see this is atrial fibrillation with what we call a rapid ventricular response, meaning you can see that it looks very fast. These intervals are very close to another. And you want to get to the point where you have atrial fibrillation with controlled ventricular response. And so that is often achieved with using medications to just slow down the heart rate a little bit. It doesn't necessarily make the AFib go away, but if you can slow down the heart rate a little bit, that will buy you time. You can make it more manageable. We do have some patients who, even without medications, their atrial fibrillation doesn't go that fast. When they go into atrial fibrillation, their heart rate maybe only goes 80 beats per minute, 90 beats per minute, maybe a little faster than their baseline, but not appreciably fast. And those patients who don't go that fast, they tend to be the patients who don't really feel their AFib so much. So really, the heart rate is a big determining factor in how symptomatic patients can be. And so it can be tricky to catch AFib in the patients who don't go so fast with AFib. So again, getting to the theme that everyone is a little different. How fast does your AFib go? Well, that's kind of dependent on you and how your heart is wired. Pacemakers can sometimes have a role in atrial fibrillation management. It doesn't directly treat atrial fibrillation, but pacemakers treat slow heart rates. And sometimes if you are being hindered by issues with slow heart rates when in atrial fibrillation or when in normal rhythm, pacemakers can have a role, but they're not necessarily this first-line treatment for atrial fibrillation. Now we're going to talk about the third pillar of atrial fibrillation. This is called rhythm control. So unlike rate control, where we're trying to just get the heart rate under control, but you're still in atrial fibrillation, rhythm control is actually the effort to get you back into normal rhythm and to actually suppress atrial fibrillation, keep the episodes from happening in the first place. And this is, as electrophysiologists, what we do well. This is what we get paid to do. Your primary care doctors, your cardiologists, they can do rate control. They can help reduce stroke risk by using blood thinners. But this is, for us, the electrophysiologists, this is our time to shine, which is to try to make efforts to kick you out of atrial fibrillation and get you back into normal rhythm. And there's multiple ways that we can do that to try to maintain normal rhythm. There are antiarrhythmic medications, and we've got a list of different options at our disposal. And which one is best for a particular patient depends. It depends on what else is going on with the patient, how far along their atrial fibrillation is, what other medical issues they've got going on. And so that will dictate the choice of the antiarrhythmic drug. So that is one option. There is a very relatively simple procedure, something called a cardioversion, where we shock your heart back into normal rhythm. So it's a procedure where an anesthesiologist puts you to sleep for just literally like a minute or two. And using this external defibrillator, just like you see on TV, they put some pads and patches to your chest and deliver an electrical current. And you can see on the EKG here that someone's in atrial fibrillation. They deliver a shock, and then you're back in normal rhythm afterwards. So that's a procedure that can get you back into normal rhythm, although the cardioversion doesn't do anything to keep you in normal rhythm. So, but the cardioversion does have a role for some patients. And then something I'll talk about later is something called an ablation procedure, which is something we do a lot of. It's our most common procedure. We do it all day, every day, and we'll talk a little bit more about that. So pursuing rhythm control and the decision to try to get you back in normal rhythm, it is a very individualized decision. There are some patients who, when they go into atrial fibrillation, their rates are controlled. They feel absolutely no different. They feel no symptoms. And even when I put them back in normal rhythm and I do a cardioversion, I get them back in normal rhythm, and then I ask them, hey, don't you feel better now? I got you in normal rhythm. Don't you feel good? And the patient says, no, I don't feel any better. I don't think anything's better since you put me back in normal rhythm. I still do my thing. I still exercise. And so their lot in life has not improved. So for those patients, sometimes we just say, you know what, maybe it's not worth going down this road of antiarrhythmics and doing ablations if you don't really feel a difference in atrial fibrillation in the first place. But again, getting to the idea that sometimes the symptoms can be subtle. And only after you get people back in normal rhythm and then you make them exercise and put their heart through its paces will they actually discern a difference. And that really requires the probing questions of a good doctor and a good clinician and a good electrophysiologist to kind of suss that out. And sometimes rhythm control, it's not possible. If someone has had AFib for years and years and their atrium is dilated, their atrium is scarred, they've gone through this remodeling process, sometimes I, as an electrophysiologist, will say, I don't think I can beat this. I think the atrium is a little too far gone, and we can't get you back in normal rhythm. So you can, I get referrals for that sometimes when someone's had atrial fibrillation for 20 years, and unfortunately, there's not the ship has sailed, and I don't think we can get him back in normal rhythm. So this is an ablation procedure. This is a diagram where someone is, there's a patient under this drape here. And what we do is we get wires and catheters through the veins of their leg, the femoral veins, and we put wires inside your heart. And through those wires in the heart, we can make maps of what your atrium looks like and ablate or destroy tissue, and that leads to atrial fibrillation. And there's lots of ways in which we do this. This is, again, our most common procedure, and we do it a lot. And there is a lot of new technology and new advances in how we ablate that makes our job fun and interesting, and also has been just a huge benefit for our patients. I remember when I was training in AFib ablation, this used to be a pretty long procedure. It used to be a 3-hour, 4-hour slog for each patient. But now we have advanced so much with our ablation technology where we can do it now in like an hour, hour and a half. I've done a procedure in 45 minutes. Again, I'm not trying to set records or anything like that, but the tools they put in our hands to do this ablation procedure gets better. And I think our patients have been the beneficiary of this. Now, the cornerstone of atrial fibrillation ablation is something called pulmonary vein isolation. And what are the pulmonary veins? Well, they are these structures in the left atrium that drain blood from the lungs into that chamber of the heart, the left atrium. And a lot of the electrical discharges that lead to atrial fibrillation come from these pulmonary veins. So what we are trying to do is isolate these pulmonary veins by creating almost like a fence of scar around these pulmonary veins so that any electrical triggers inside these pulmonary veins cannot leave the veins and go into the atrium to trigger atrial fibrillation. So one way that we can do this, the way that it's been done for decades, is something called radiofrequency ablation, where you get a wire, you put it on these different points here, and you burn and cauterize the tissue, and you create scar that way. And so you go point by point around this, and you can create that fence of scar, and that achieves the isolation. You can also ablate other structures here. These ablations here is for something called atrial flutter, which can be done. There's also a very common modality, something called a cryoballoon ablation, where you freeze the tissue. So you can see here that you can have this balloon that can turn very, very cold, freeze tissue, and destroy tissue that way. And then that can create this ring of a scar around the pulmonary vein that can, again, isolate the pulmonary veins and prevent those triggers from triggering the atrium into atrial fibrillation. And now the newest technology that is now kind of in its first generation is something called pulse field ablation, where you can get these devices that don't burn, they don't freeze, but they can, what I would say is deliver an electrical shock to the tissue here. It's almost like electrocuting the tissue, and that causes the tissue to undergo programmed cell death and basically cause the scar that way. And that is a new energy source that is used for atrial fibrillation ablation that we now have at our disposal. And so every patient is different in what would be best. There are certain situations where perhaps radiofrequency ablation would be better than cryoballoon or pulse field ablation. And there are certain patients in situations where pulse field ablation would be better. So really having a doctor, and most electrophysiologists are facile in multiple modalities, it's different for every single patient in which approach you would choose. This is what pulmonary vein isolation looks like. We can see that here, these kinds of parts here, these little things sticking out is the pulmonary veins. And what we do is we create little dots. This is with a radiofrequency ablation, where we create ablation lesions all along these pulmonary veins. And you can see here that it turns gray on the picture. And what that represents is that there is no more electrical activity within these pulmonary veins because you've isolated them, because you've fenced them in, and no more electrical activity goes in. So that's pretty much what we're doing during an ablation procedure. We're drawing little circles around the pulmonary veins. I say it's like playing a video game. I grew up playing a lot of video games, and it's prepared me well for my job today as an electrophysiologist, drawing circles around these pulmonary veins on a screen. Now, we talk about the last pillar of atrial fibrillation management, and that's reducing the stroke risk. And we assess an individual stroke risk based off of a scoring system that we use called the CHADS-VASc score. And it's a score from 1 through 10, or actually 0 through 10. And you get a point for each of these diseases or demographic risk factors that you may have. And if your score is 10, that's the highest risk of stroke. If your score is 0, that's the lowest risk of stroke. And so usually if someone has a score of 2 or above, the recommendation is that we should start such patients on blood thinners because the risk of strokes and blood clots is high enough where we think starting you on a blood thinner is worth doing. Even though blood thinners have issues, they can make you bleed more, and that is a risk we do take seriously. But we also have on the other side risk of stroke, and we don't want blood clots to happen either. So it can be a really tough decision sometimes for some patients who've had bleeding issues or bleeding problems to decide about blood thinners, and that really is a very individualized decision per patient. Really, it takes getting to know a patient's history, knowing what their experience with blood thinners has been like, what their risk score is for developing a stroke. And this CHADS-VASc score, it's a fairly blunt instrument. Obviously, these categories aren't the only things that one should consider in whether you are at a high risk for blood clots or not. Certainly, there are diseases that predispose some people to having blood clots, but that isn't necessarily accounted for in the CHADS-VASc score. We believe that patients who've had a history of cancer or malignancies, for example, they might be higher risk for blood clots, although that is not reflected in this score. So although this CHADS-VASc score is a very helpful tool, we use it a lot. It's not the end-all be-all, and it really does boil down to a patient's discussion with their electrophysiologist as to the benefits and risks of starting a blood thinner. There are also something else that requires a careful, nuanced conversation with your electrophysiologist are these devices that can be used to potentially reduce the risk of strokes in patients. And so one that you may have seen is something called the Watchman device. And what that is a plug that blocks this structure called the left atrial appendage. And it is thought and it is believed that a lot of the blood clots that form from atrial fibrillation form in the left atrial appendage. And so what you can potentially do is put a plug there and block off the blood flow. So any blood clots that develop here can't leave the atrium and go into your heart and into your brain and cause a stroke. Now, again, there's some potential risks with this procedure. It presupposes the idea that all the blood clots come from the left atrial appendage, which I don't think is true, but it can be an option for some patients. There's also another example of left atrial appendage occlusion, something called the AtriClip. And this is done more by our cardiac surgeons, where they will literally put a clip that ligates or almost like strangles and clips off the left atrial appendage so that none of the blood inside that little appendage can form a clot and leave the heart into the brain and cause a stroke. So really, just talking about this idea that atrial fibrillation requires a very personalized approach, it also takes a village. There's a lot of patients who need a multidisciplinary team. And that has been the trend in managing atrial fibrillation is you don't need, it's not just the domain of the electrophysiologist, and the electrophysiologist is a one-man show in managing the atrial fibrillation, but we need our cardiologists involved. We need our primary care physicians involved. We need our nutritionists to be involved. We need our sleep specialists to be involved. We need our pulmonary specialists to be involved. We need our kidney doctors to be involved because that definitely can have a role in managing atrial fibrillation. So it really requires a multidisciplinary approach, and that is something that we're proud to offer here at Virginia Heart and with Innova is a multidisciplinary approach to your atrial fibrillation. So that really is a big way of attacking this. So just the key points I wanted to emphasize for today is that atrial fibrillation, it's very common, as you guys have seen the numbers. It's only going to get even more frequent. But again, every patient's experience is different. And so the treatment approaches should be different. And really, that's what makes it interesting for us. Atrial fibrillation is not a one-size-fits-all approach. It really does depend on the patient's individual issues. And I think that's what makes our job fun. Just getting to talk to patients, hearing about what's important to them, how they're experiencing atrial fibrillation, how it's affecting their life, what impact it's had on them. that is such an important part of the story. And you really need to have a good doctor who will listen to you and listen to your story, hear about how it is affecting your life, asking the right questions, asking you the right questions, and learning from your experience, and from there making a game plan. And education and awareness is crucial. So I encourage my patients to read up all they can about atrial fibrillation. There's plenty of resources on the internet about atrial fibrillation, but again, because every patient's experience is different, you really need your electrophysiologist to put all that you've read into your own clinical context. Because again, what you've read and how it applies to one patient does not necessarily apply to your situation. And again, there is no cure for atrial fibrillation. So we talked about how aging is an inexorably progressive disease, but we can deal it decisive blows with things like ablation or with antiarrhythmic drugs. But even after an apparently successful ablation, I do tell patients that I didn't cure your atrial fibrillation. It will probably come back. I hope it's many, many years from now, like 10 years from now, but it can come back. And so that's why having this longitudinal relationship with a good electrophysiologist, someone you trust, someone you get along with, someone who you feel really understands you and listens to you, is really critical to having a successful management and a journey on atrial fibrillation. And it is a journey we take together. I have the privilege of having that journey with a lot of patients, and it really makes this part of my job very, very fun. So with that, I'll conclude. This is some contact information about our atrial fibrillation center and our heart rhythm center at Virginia Heart. And with that, I'm ready for some questions.
All right, Dr. Lee, that was outstanding. I'm going to ask you to pull the slides down so people can see us.
Yep.
And
Okay.
what I'm going to try to do is kind of summarize some of these questions into categories and try to whip through them quickly with you. So I'm going to start with one of my favorite topics, which goes back to wearables, because I think wearables have been a game changer. I think all of us have been able to make a diagnosis simply by a rhythm strip that a patient brings into the office with them. But I think folks may be a little confused when you talked about some of these devices, whether it's an Apple Watch or Samsung Watch or whatever it is. And so I'm going to ask you a two-part question. First of all, there are some devices that will give you a warning that'll say you may be in atrial fibrillation. You know, that may not be accurate. That's just saying that it picked up some irregularity, but it doesn't mean you have atrial fibrillation. And then what you said, I believe, was, there are some that you can actually record a rhythm strip. You can record an electrocardiogram, but we don't expect our patients to be able to read that electrocardiogram, right? So what should they do if they have a device like an app? And I can't tell you how many patients I've had to teach how to use their Apple Watch, right? They
Yeah.
have the ability to record their electrocardiogram, but they didn't know they did. But what should they do once they record something and they think maybe they were in atrial fibrillation?
Yeah, that's a great question. And I agree with you 100%, Dr. Levy, that I think these devices have been a game changer and really enhanced our care for atrial fibrillation. So I am a big fan. And now, so to your question that, these devices can sometimes ping you, especially these wearables that can detect an irregular rhythm. And yes, there is the possibility of false positives where patients, it will ping you, but it's not actually atrial fibrillation. But I would say in my experience that they're pretty good. Obviously these devices and the makers of these devices have a vested interest in not having too many false positives, because then a lot of the electrophysiologists will rise up and yell at these companies. So again, they do what they can to minimize false positives, but that possibility still exists. Now, again, I think, how do we know for sure? And the key is that EKG tracing. That is truly the key. So just having an irregular heartbeat detected is not enough. You need a device that will actually get you an EKG. And again, there are some that do. There are some where you actually can get an EKG tracing and it can save it as a PDF on your app or on your phone. And then there is some artificial intelligence with these where it can actually try to spit out a diagnosis where it'll say atrial fibrillation or possible atrial fibrillation or inconclusive or sinus rhythm. And it's pretty good, but it's not perfect. And it really does require a cardiologist to overread it. And so what I'll usually have is the patients will bring their phone with them and their app with them, and I'll pull up their app and I'll go through their history and look at every EKG tracing that they've had, and I'll flip through them and I'll be, nope, that's not atrial fibrillation. This thing is wrong. and I'll feel confident
Right.
about that. And then other times where I'll say, I know it doesn't say atrial fibrillation, but boy, this really does look like atrial fibrillation. So again, the critical key is that EKG tracing. You can't just bank on just the heart rate being a little irregular or the heart rate going a certain rate. You can't bank on that. You really need that tracing.
Right.
So if you're going to find a device that that purports to catch atrial fibrillation, really try to make sure that it can obtain an EKG tracing.
Yeah, I think it's important for people to realize you can have an irregularity of your heart rhythm that is not atrial fibrillation, so you don't have to get worried. You know, an issue that didn't come up, and patients ask me this a lot, is when should I go to the emergency room, right? And so I have a history of paroxysmal atrial fibrillation, on and off atrial fibrillation. Just because I feel like my heart's going irregular, do I have to run in? Is it an emergency? Or perhaps when is it an emergency? When should patients immediately seek medical attention?
Yeah, that is a tough question, and one that, again, speaks to the individualized approach, right? That is such a critical part of it. If and that differs based off of how severe their symptoms are. So obviously, any severe symptoms where you're feeling very lightheaded, having worsening chest pain, very short of breath, you're having trouble even walking to the bathroom or up the stairs, and you're like really struggling, that is not good. And therefore, we would usually recommend with such severe symptoms, you really got to go to the emergency room to figure this out because it could be atrial fibrillation or it couldn't, right? Some people or a lot of patients are trying to look for, well, what's the heart rate cutoff? Where if my heart rate is this fast and then I should go, and then if it's below, I'm fine. There really is no heart rate cutoff. Obviously, the higher the heart rate, if I'm seeing 150 beats per minute, yeah, I'm a little nervous. I think that's not something we want to sustain for long periods of time. But even if someone's heart rate is reasonable, like 90 beats per minute or 100 beats per minute, but they feel those severe symptoms, then I say, I don't care that it's 90 beats per minute and that seems okay. If you feel that bad, you got to go. And then on the flip side, patients can have heart rates up to 120, 130 beats per minute. And then I talk with them on the phone and they're saying, yeah, I feel fine. I mean, it just feels a little weird, but I'm okay. And then we tell them, you know what, maybe not. Maybe you don't need to go to the emergency room and spare yourself the whole circus of going to the ER and all of that. So it's very individualized, and that's why we recommend, people call us and have someone talk them through it.
Sure. Thank you. Let's get to probably the next most frequent question I get, right? And it has to do with anticoagulation. And it has to do with how long do I need to be on anticoagulation. So someone who is in persistent permanent atrial fibrillation, they're on anticoagulation forever until they can't be, right? But let's say you do an ablation on me and it's now 6 or 12 months down the pike and I'm in normal rhythm. Can I come off blood thinners? Or if I just had paroxysmal atrial fibrillation once after surgery or after an infection, a pneumonia, am I on lifelong anticoagulation? How do we decide how long someone needs to be on anticoagulation? I know there's no answer to that question, but it's go ahead.
Yeah, I mean, I'm gonna sound like a broken record, but the answer is it depends, and it depends on it's personalized for every single patient. And so again, the theme of my talk, it's very personalized. I think actually, so there are these recent new AFib guidelines that came out in the beginning of this year, hot off the press. There's new AFib guidelines. We've redone kind of all of our assessments of atrial fibrillation. And when it comes to this idea of when to come off the blood thinner, should I be on the blood thinner? My AFib is gone. Do I still need to be on it? We were kind of hoping, some people were hoping that it would just kind of give you this answer that's kind of cookbook and recipe. It did not do that. Really, the term that they used when it comes to blood thinner is this requires shared decision-making with the patient and the physician. And so that doesn't make our job any easier because we've got to have those tough conversations with the patients. We've got to know their backstory. We've got to know what they've been through with bleeding. Cost becomes an issue. Patient preference becomes an issue. We lay out the risks, we lay out the benefits as best as we can, and then together, the patient and the physician, you try to make a decision. So we're just trying to learn as much as we can, but really the patient's preferences and the physician's preferences kind of have to meet together, and you make a decision from there.
Great. Yeah, I knew you were going to say that.
Yeah, I know.
So there are a lot of questions. So I'm going to kind of throw them at you. Let's try to give maybe some brief answers so we can try to get through a bunch of them. A quick question. Someone said, hey, if you're on a blood thinner, does the dosage change with age? And I'll add, does the dosage change with kidney function, or does, are there medications that you have to change the dosage depending on other things going on?
The answer is yes. There are different doses based off of, like you said, the kidney function, other factors such as age, your weight. So yes, those doses need to be adjusted appropriately for you.
And
But that doesn't require a big discussion, thankfully. Usually that's
Right.
pretty cookbook.
Right. There was also a question about the relationship between atrial fibrillation and coronary artery bypass surgery. That we sometimes see patients go into atrial fibrillation briefly after bypass surgery. Does that have the same meaning? And I think many patients will find they're put on a medication for a while after bypass surgery just to prevent
Yeah.
it. Is that kind of a different category?
Yeah, so there is something called postoperative atrial fibrillation. And so if you had bypass surgery or if you've had open heart surgery of any kind, yeah, I mean, the surgeons are in there, they split your chest open, they're mucking around in the heart, and everything's just inflamed and hot. And that can lead someone to have atrial fibrillation by virtue only of the fact that everything around your heart is hot and inflamed. And so we'll see that those patients, as they're recovering from surgery, they have atrial fibrillation. And then very often afterwards, they don't necessarily go on to have atrial fibrillation long term afterwards. However, in those recent guidelines that I talked about earlier this year, the recommendation has been for anyone who's had postoperative atrial fibrillation that we counsel those patients now to be vigilant for any recurrences in the future, because not every patient who undergoes bypass surgery goes on to get atrial fibrillation ever. They don't get AFib at all during their recovery when they're in the hospital. And a lot of patients who get open heart surgery, they're fine. They never see a peep of AFib. So the fact that you had AFib after your bypass surgery probably means that you are somehow perhaps predisposed to having AFib down the road. Yes, there was this big trigger and exacerbator of it with open heart surgery, but we tell those patients, hey, you've had it here. It's probably the surgery, but look out for it, using these watches or devices. So that's now the recommendation.
Okay. So real quickly, what's the difference between atrial fibrillation and its cousin, atrial flutter?
Yeah, so you'll probably hear that term a lot. They are very closely related, and they can have many of the same manifestations. So in terms of how patients experience it, atrial fibrillation and atrial flutter, it can be nearly identical and very similar. Same symptoms, short of breath, lightheaded, makes your heart go fast. The difference is atrial flutter tends to be a little more what we call organized. So atrial fibrillation, if you could see my hand there, atrial fibrillation, if your atrium is very just kind of chaotic and just fibrillating. Atrial flutter tends to be a little bit more of an organized rhythm where it's fluttering, but it's a little more organized and not so chaotic. But it can still make your heart go fast. And the reason this distinction matters is certainly in the ablation space. That would be different targets for ablation, different approaches for ablation. So yeah, that is an important distinction to make for the electrophysiologist. But in terms of how patients experience it, it can be very, very similar.
In the old days, I was an interventional cardiologist. I am an interventional cardiologist. Used to tell patients atrial flutter is much easier for them to ablate, but now you guys are so good at everything. I don't think we can say that anymore. All right, there were a whole bunch of questions about ablations. All right, I'm going to ask you first, and you sort of alluded to it, but I didn't hear you make a strong statement on this. Is the pendulum swinging a little bit in the electrophysiology world to move patients much sooner to a definitive therapy like ablation? And you mentioned that earlier in the course of the disease to have better long-term outcomes versus, I'm a 50-year-old, I'm an AFib, I have a normal heart, normal valves, I feel okay. Yeah, but what happens when I'm 70, right? And should we try to restore, normal rhythm earlier in the course of the disease and move patients sooner towards that therapy?
Yes, the answer is yes. And I wouldn't even call it a pendulum. I would call it a progression. This is how modern medicine is moving. And we are now much more aggressive about trying to treat atrial fibrillation early. There is a lot of emerging evidence that atrial fibrillation and having it for years and years does lead to some downstream consequences. And again, the conventional wisdom, perhaps a few decades ago, when we could not necessarily treat atrial fibrillation as effectively as we do now, atrial fibrillation is not a bad idea. It's not a big deal. If you don't feel that poorly with it, let's just leave it alone, and you'll be fine. That is not such an embraced approach now, because now there is a lot we can do about atrial fibrillation. We talked and alluded to the fact that if you nip it in the bud when the atrial fibrillation is paroxysmal, you can prevent this progression. And there is emerging data to show that having this early intervention for atrial fibrillation, that it can improve mortality, that it can improve lifespan. Now, we're very reluctant to ever make that claim that an intervention improves lifespan and mortality, but there is evidence to show that that may be true. And certainly for preventing downstream issues like heart failure and preventing strokes, there is, again, a lot of data to show that this is really where our field is going, where we are trying to ablate early, intervene early, just get this dealt with to prevent potential downstream issues down the road. So again,
Okay,
different for every patient.
So if I was considering ablation and I asked you, what's the success rate in general of ablations?
Yep.
And this corollary is, if I have an ablation and I go back into atrial fibrillation, can I get a second ablation?
Yeah, and the answer is yes.
Question.
So the success rate for a first-time ablation for getting durable suppression for a year and beyond, we say it's about 70 to 80%. And if you don't fall into that 70 to 80%, if you let us take a second crack at it and do a second ablation, the cumulative success rate goes to 80 to 90%. And sometimes it is, the first ablation, it just doesn't take for some reason. They get recurrences quite early on. And then you do the second ablation where you can build on the work you did the first time. And then you get that durable suppression for years that you're really looking for. So that definitely is something that we are trying to do. But again, because the tools are getting better, we're finding that the need for second ablations are becoming a little less. And also, I think because the experience is getting better, again, sometimes we can do these in an hour, if we're really, really fast. Patients are more willing to sign up for a second ablation because they say, yeah, that first ablation was no sweat. It was pretty easy. I'll do another one. And so that's really improved our care.
By the way, on a personal note, I will take issue with you declaring aging as a chronic disease or something like that. And we're all still looking for the cure, but I just, I wanted to make my objection heard. There was a question about pacemakers and MRIs. And I know this isn't a pacemaker talk, but it's something people think about. I got a pacemaker, I need an MRI. What's going on these days, especially with the modern pacemakers?
Yeah, so pretty much every modern pacemaker and the pacemaker leads are also a component to consider, are MRI compatible. So usually there is not much difficulty with getting it with pacemakers that are implanted these days. However, there are older devices and that are still out there, patients with older devices, older leads, where getting an MRI is a little bit more difficult and is not technically MRI safe or MRI compatible. However, we do MRIs on those patients all the time. Patients with really old devices, 30 years old, leads that are very old, there is a way to get MRIs done in them. It does take a little bit more extra homework and box checking to make sure that it can be done in a safe manner, but it absolutely can be done. And don't let anyone stop you from getting an MRI that is absolutely needed for some other issue, like an orthopedic issue or a neurologic issue, just because you've got a quote unquote MRI, not conditional pacemaker. We can find a way to make it happen. An electrophysiologist should be able to make that happen.
And I will mention that there's a coordinated response between Virginia Heart and Inova Cardiology for these pacemaker issues that has been well put together. So if you do have a pacemaker and you're a patient of one of those practices, you can just call and they can give you an answer right away. So that's been very helpful. You talked about triggers, and someone wanted to know whether, having an infection could be a trigger, and certainly pneumonias, but also someone asked about COVID. And are we seeing more AFib after COVID, which is an inflammatory disease? What do you think?
Yeah, that's a tough one. I think when it comes to all things COVID, I mean, I don't think anyone really knows what they're talking about. I think it's just such a new thing. It's unprecedented, and it's really hard to know. But again, absolutely any kind of illness, even the flu or RSV or just a common cold, can certainly be a trigger for atrial fibrillation. And then people ask about the vaccines. Could that be a trigger? And I would say, of course it can. I mean, that it can always be theoretically possible. However, I would say I don't think there's anything special about COVID or vaccine to make it particularly more likely to lead to atrial fibrillation versus other vaccines versus other illnesses. So it's not like business has been booming and skyrocketing after COVID happened, for atrial fibrillation. Business was booming plenty before COVID came around. So, I don't think we've seen an uptick in AFib just because of COVID.
Okay, great. There are a lot of questions about medications and adjusting medications and having other procedures if you're on medication. The one thing I'll mention is with COVID, Paxlovid, if patients are on a large number of cardiovascular medications, if you're going to need to take Paxlovid, you will likely need to either stop or change dosage of certain heart medicines. But there was a question about if I'm going to have some operative procedure and I'm on some of these heart medications, does that prevent me from having a procedure? And I guess the question would be anticoagulations and antiarrhythmics. How do you approach that? We're almost at the end. We're going to have to keep it brief.
Yeah. So usually we like to keep patients on antiarrhythmics when they're going through surgery because obviously, yes, we want you to not go into AFib during your surgery. Now, when it comes to anticoagulation, the blood thinner, we're usually pretty comfortable holding blood thinners for a period of time just so you can get through your surgery safely. It's not like if you stop the blood thinner, the next day you're going to have a stroke. That's not how atrial fibrillation works. Usually the blood clot is for long-term prevention. So usually we're very comfortable holding the blood thinner. There's certain situations in which we're not so comfortable. It depends on the situation, going back to that theme, but generally it should not be a problem.
The other thing I always like to mention in an AFib talk, when you talk about triggers, it's alcohol, and it's the concept of holiday heart. Someone who goes and is off on vacation, drinks more alcohol than they're used to, and then about 8 hours later, suddenly their heart's racing and they've gone into atrial fibrillation, and we call that holiday heart. Does that pose a risk to them long term? Do you know, is that a risk factor, or is that just something we see?
Yeah, well, we've seen some emerging data that even a single drink of alcohol can incrementally raise your risk of going into atrial fibrillation. And then obviously the more you do, the more you're increasing your risk. However, that being said, I think what we like to do is just smash your AFib via ablation or antiarrhythmics so that you can have that one drink without having that fear and monkey on your back. So, we say, let us take care of your AFib and have that good drink. As long as it's good wine with good people, that's what we want. And as long as it's done in moderation.
Right.
Yeah, it's good people. Don't do it by yourself. Don't be alone when you do it.
We're actually out of time. So Dr. Lee, I need to thank you. This was a great session.